Good afternoon, everybody. Thank you for joining this session of the 2021 North Country Leadership Summit, Emerging from a Year of Change, an opportunity to rebuild and reimagine. Before I turn it over to our presenter, we would like to quickly thank our sponsors for this summit. We could not put on this event without the support from our very generous sponsors, so thank you very much. We want to just go over a few housekeeping items. Please place all questions and comments in the chat box, and we will ensure they are addressed during the Q&A at the end of the presentation. All attendees should be muted and video off throughout the presentation, which will ensure the best broadband connectivity and reduce distractions. And finally, all presentations are being recorded and will be archived on the North Country Leadership Summit website by October 1st. With that, I'm going to turn it over to Laurie Lavasser, a population health consultant, to give us a presentation on a telehealth home visit program.
Thank you very much, and welcome everybody. I'm happy to be able to present this care model, and I hope that it will be helpful for other primary care or clinic practices who are looking for care models in this day of COVID. I had presented this care model on the spur of the moment, of course, as COVID was starting to arise, and it was not piloted. And it was for a federal health care clinic who had medical care, OBGYN, newborn, pediatric care. We also had behavioral health involved, substance abuse services, triage nursing team. So our telehealth home visit program was primarily for homebound patients. And the homebound patients, sorry, I just lost my screen. Let me see if I can bring it back up.
You may have to hit reshare screen, Laurie, because it's not showing on our end yet.
Okay. Okay, does everybody see my screen now?
Yep.
Okay, thank you very much. I apologize for that delay. So several services that were embedded in the clinic, and this telehealth home visit program was primarily designed for homebound patients. There was a number of patients based on the data that was collected that were homebound and did not have access to any type of internet or web. So a lot of these patients had flip phones. A lot of them were not only homebound, but they were 65 years and older, and in the time of COVID, they were quarantining themselves as a protection until vaccination. The clinic that I served also had a dental component, ophthalmology. We also had case management, social work on board, and outreach and enrollment. Embedded in this telehealth home visit program was a social determinant of health screening that we had decided to get outreach and enrollment started on because, as you know, statistically speaking, anyone who does not have health insurance most likely has other social determinants of health. So we redesigned that structure of her role and function and included social determinant of health screening and got the person on board with the Unitas platform and got her trained. This specific clinic serves over 17,000 patients, various populations. The primary population was Black African American. We have a large Spanish population that was served, Guyanese, Arabic, Asian, and Asian Indian. There's 2 locations that I worked with in Schenectady and Amsterdam. The Amsterdam location was primarily Spanish. So social determinants of health focus was both on telehealth home visit program and our outreach enrollment program. We saw how successful it was in those two programs and decided to roll it out into the primary care clinic. The strategy, of course, as mentioned, was to be able to see patients who did not have web enablement. So on March 20th, 2020, we launched the Telehealth home visit program, and we were able to do the social determinant of health assessment as well. It was completed in the electronic health record. And we had it embedded into the electronic health record. We started out with the prepare form and noticed that a lot of the patients weren't really happy with the questions embedded in the prepare form. Some of the elderly patients thought that it was not important for us to know whether or not they graduated high school, which makes sense. We did an evaluation of safety in the home while we were in there, and we had also helped patients to be able to get their food needs met. We had switched over to the health leads form, which does focus on food, and it focuses on transportation. In this slide program, you'll see a copy of the health leads tool so that you can get an idea of how that tool actually works and focuses on the primary needs of life in everyday living. Once we were in the home, patients felt very safe with us. We did do COVID screening the day of and also day before by asking the questionnaire over the phone. And once we got in the home, we had asked patients if we could check their refrigerator, and that's how we were able to identify a lot of the food needs. Because we had found that most of the patients that had a social determinant of health need and maybe had it for a long time did not know that they even had a need because they were so used to living without. So we visually looked at the home each time we went in. Anybody who answered yes to 2 or more questions would have been referred to the case manager so that they could follow up on any additional needs that might take a little bit longer to resolve for the team in the home. So when outreach and enrollment started, we had a brand new person in the job. And she was really eager to start this redesign program. And she had really done very well. She was doing a lot of referrals at the time over the Unite Us Healthy Together platform. And she also put into practice that if there were 2 questions answered that identified a need for a patient, then case management would be notified. When we rolled the social determinant of health screening out into the clinic, nursing was performing the health leads assessment while rooming patients in the clinic. And then the nursing team and provider would huddle to discuss any social determinants of health needs that were identified. A referral would be made at that time over the Healthy Together platform based on the needs. And again, if there were 2 or more identified needs, then case management would be notified and the patient would be seen by case management. We would also evaluate patients that were coming into the clinic for a need for a social worker just because of COVID being a very stressful time. And the social worker would go see the patient in the clinic right away for counseling. So as mentioned, we had the social worker also on board. This brings us to our first polling question, and you can just type your answer into the chat. at your respective health center or primary care. And if you have outreach and enrollment embedded in your service needs for patients, do you use a standard social determinants of health screening tools such as Prepare or Health Leads? Yes or no? I'll just give everybody a few minutes to answer that. And any questions that you might have as we're going through the series of slides, please feel free to chat them in the chat box, and I'll be happy to answer them as we're going through so we don't lose our train of thought on the question. And this was the algorithm that was developed around social determinants of health. This was the same algorithm that we used for the telehealth home visit program. One thing I did want to mention with the telehealth home visit program, we did send out 2 people to the home, and we would set up the computer. So go with 2 computers. One computer was for entering vital signs and such, and the other was set up so that the patient could have their visit with the provider. And we also did a medication reconciliation at that time in the home, and discovered quite a bit with that med reconciliation. It was quite an eye-opener for the team, where, you know, generally patients don't bring all their meds to the clinic in person, but when you're in their home, you can see everything that they're on. So this algorithm reflects what we did. If a patient had 1 or 2 more needs, we had champions that placed the referral into Health Lead Together, and we would hand that off to the case management team.
Hey, Laurie,
I'm
just wanted to
sorry.
let you know, it looks like we have 1 yes and 1 no for your poll. So half and half. Okay,
thank you. That's good. It's great to know that people are screening. It is essential for healthy outcomes. This is a sample of the Health Lead screening tool. And as you can see, it addresses food, lights, housing, also childcare, any financial difficulties that might be identified with the patient, transportation needs, understanding hospital materials, which, believe it or not, we have a lot of patients that answer yes to that question. So we do get patients connected to a case manager right away when they're answering yes, because we identify that if they don't understand their post-op discharges, then the outcome may not be as positive as we want it in our plan of care. Telephone is also something that we see a lot of yes answers to. So we do assist patients in that area too, to make sure that they're supported. This proved to be a more popular tool, I think, in the environment that we served, in the population that we served. They're very direct questions, and the patients answered a little bit more directly, and we were able to get them the help that they needed. So I'm not sure if you are all familiar with Unitas Healthy Together platform. They are one of the sponsors that was listed earlier, and it's a platform that is in partnership with Alliance for Better Health, IPA partnership. They are a national platform, and we were using them to help with the coordination of care. And what we would do is we would have a champion place the referral. Once the referral is placed into Healthy Together, it goes into a coordination center where the coordination center actually connects the patient to the needs that we actually placed as the referral. So once we place that referral, now we're working together with the coordination center to make sure that the patient's needs are met. We have recently done some improvement with some of our collaboration because we were having difficulty with patients answering their phone. If they didn't identify the number, of course, they wouldn't answer the phone. So recently, we had started handing out cards to patients so that they would know and expect who would be calling them for their needs. Education, food, shelter, clothing, utilities, employment, legal needs are all found as referral options on this platform. The platform has the capability to share documentation with all parties involved with the patient, and you're able to do your communication right over that platform as well. The Health Leads assessment tool, as I mentioned, was used at the time, and we had assessed a total of 1,261 patients for the year of 2020. So a lot of referrals were placed over the Unite Us platform as well. And for our telehealth home visit program that was designed and implemented March 1st, 2020, there was a total of 273 patients seen to November 14th, 2020. So from March to November, we had seen that many patients. And even after the emergency preparedness was lifted in the state of New York, the telehealth home visit program was sustainable. We continued to see patients in their home that were homebound or that didn't otherwise have web access or web capabilities to be able to see their provider. We had begun the pilot internally in the clinic about mid-October, and we started with our OB clinic. And we rolled it out one team at a time. There was a total of 96 referrals that were opened and closed during this time when we piloted the program. And it really engaged the staff because one of the OB patients that came in when we first started the pilot, it was day one, she answered yes to all the questions. So the staff were really engaged, and it kind of opened their eyes to the fact that this person, if we weren't doing the screening, would have left the clinic without getting any help at all. So during the time of December 2020, we had 29 users that were onboarded to Healthy Together, and all staff were educated in performing the social determinants of health assessment. And we decided to create 10 more users and added 4 teams. And this was in preparation to roll out to the rest of the clinic, the medical side, the ped side, and etc. So there was a total of 786 patients referred to the Healthy Together platform, and that included behavioral health and case management during that time. And over the past 30 days from the time that we had started, there was 96 referrals that had been placed and closed related to social determinants of health. Outreach and enrollment had an increased patient capacity, and they had 48 referrals that she had begun to work on, and that was over a month's time, from October to November. This is some of the data that you can gather off of Healthy Together. You can figure out how many females you've served, how many males, and their ages. And I felt that it was relevant data because some of the age groups that we're seeing that has a high incidence of social determinants of health needs were people that were in their 20s and 30s. And it was primarily females who also had children. The recent challenges that caused a redesign to take place to the care model was the limit of staffing. People were testing positive for COVID and weren't able to be at work. Staff was feeling overwhelmed as a result, and it resulted in incomplete referrals for the coordination center. It made it difficult for the coordination center to assist the patient because they didn't have enough information to be able to even get the patient connected to their needs. So we did develop frequent discussions with Alliance for Better Health and the coordination center to address the challenges. And we received much support from Alliance and coaching to be able to work with the team at the clinic and develop a stronger champion base referral team. And this is what we decided to do, that all these people that we decided as to be the referral champion team were handpicked, and that's what they would do, is just place referrals. So the care model was actually changed and redesigned, and you'll see the updated algorithm in the next few slides. And this takes us to poll question number 2 of what challenges your organization has encountered, if any, in supporting health centers or primary care in implementing patient-level social determinants of health screening and addressing their unmet social needs. And there's a few options there that has come up. Challenges in asking the sensitivity to social determinant of health questions. Sometimes patients don't always respond with a positive response. Lack of sufficient training and guidance to facilitate member implementation. Frequent staff turnover, no clear strategy for supporting social determinants of health. Too many competing initiatives. Lack of reimbursement to sustain this work. Challenges in bringing our social determinants of health screeners and scales across health centers or primary care practices. Lack of community partners or resources. There's some areas, in the state we're still trying to build up needs to be able to, community resources to meet people's needs. Challenges sharing data with community partners, closing those loops for referral tracking, or maybe you haven't experienced any challenges at all. And if there's something in those options that you would like to just chat in the chat box, please feel free. That might not be listed. And we'll give you a few minutes.
Hi, Laurie. So far, we have staff turnover in the chat.
Okay. And that was the main challenge of the particular clinic that I had developed this redesign for. Staff turnover was a huge issue because of COVID. So we can certainly relate to that. So as part of the redesign, we made some changes, educated all staff. The registration staff was designated to provide patients with a social determinant of health screening. so that patients could complete the assessment while waiting for their appointment. If a patient needed assistance with the tool, we would provide assistance. We would ask the patient, of course, whether or not they needed assistance. And as mentioned before, we developed team champions where their focus is just on making those referrals happen and placing those referrals. So they are actually the facilitators to the model. The champions place the referral and they ensure that the referral is closed out and followed up on. The champions are primarily the ones that are collaborating with the coordination center of Healthy Together. So if there's information that is needed, the champions will ensure that that information is provided so that the Care Coordination Center has a complete picture of the patient, that whole patient approach. So the goal when we did the education was to engage all staff to the social determinants of health needs of our patients so that everybody in the building appreciated, no matter what department it was, appreciated that social determinant of health needs is real. We wanted to also improve our outcomes for patients. We wanted to improve compliance with chronic health needs. Behavioral health is now using the Health Leads tool to screen more frequently because they found that when they piloted the tool that their patient population was answering those questions much more in depth than they were when they were using the prior tool that they were using. The dental staff was also educated on social determinants of health screening and was initiating screening as well. Patients being seen by the eye doctor was also being screened. So this was an initiative that we rolled out through the whole clinic, including the secondary clinic in Amsterdam. And this was the new algorithm. So once the patient answered their questions, the patient went back into the clinic, the nurse went over the questions and nurse and doctor would review the questions together. And the physician would actually talk to the patient about their needs. And again, if there were 2 or more needs, then it would be handed off to a case manager. But otherwise, the physician would place the referral in the electronic health record, and that referral would go to the champion, and the champion would then place the need in the Healthy Together platform. So this here is just some clinical metric outcomes that we evaluated during the time of from November 2020 till February 2021. We focused on a couple of patients that had some chronic conditions, hypertension and diabetes. Of patients that had type 2 diabetes answering yes to social determinants of health, there was a total of 79. And out of those 79 patients, all but 13 patients were noted to have improved hemoglobin A1Cs by ensuring their social determinants of health needs were met. The patient examples that we have here to share is a hemoglobin A1C of 15.5 that was recorded on April 27th, 2020. And then it was repeated in August 7th, 2020. And we showed a significant decrease to 11.8 in the hemoglobin A1C on showing an improved value with the social determinants of health needs being assessed at that same time. And the second example, proves the same, where it was almost cut, in half. A hemoglobin A1C of 8.7, October 28th, 2020, and the improvement in January 21st, 2021 was 4.8. Blood pressure control, as mentioned, that is something that is significant in a lot of patients that have social determinant of health needs. It is statistically known that people that are suffering from social determinants of health have hypertension. So 49 patients that screened yes for social determinants of health, out of that 49, 26 were improved and controlled in our hypertension program. They had their needs met, as well as being in our hypertension program, so that we could monitor and have a patient engaged care plan that meets their needs. And this takes us to our next polling question. How frequently does the health center or primary care team review the social determinants of health, social risk factors data with patients? Do you do it on each visit when the patient comes in? Are you assessing with each visit, or is it every 3 visits, quarterly, semi-annually, or annually, or maybe you're not conducting screening at this time? And please feel free to type that in the chat box. We'll give you a few minutes.
Hi, Laurie. We
Yes.
got one response in the chat that one of our partners does a brief assessment at each visit.
Great. So during COVID, we were doing an assessment with each visit as well. We're still in COVID technically, but when it was a little more intense and everyone was on quarantine and people were having difficulty having access to care, each visit we were checking social determinants of health. And one of the reasons for that was because we were watching the trends in the Capital District, and the trends in the Capital District showed that food disparity was at its highest at that time. So we felt that the need to check a patient every time they came in for each visit was a necessity, just because something could change as they walk out the door. Somebody gets a phone call and finds out maybe they've lost their job or they're going to lose their apartment. One never knows, but we decided that each visit at that time was essential. Currently, as New York State was starting to open up and things were starting to improve, and we were watching the data in the clinic to see how the patient population was doing by way of social determinants of health. We had reduced it down to every 3rd visit. So it really depends on your population. And I think it also depends on the area of what community connections that are available as well in the area. I know that Healthy Together is growing and we want it to grow. I do know that when we were instituting a lot of these social determinants of health over Healthy Together for our Amsterdam clinic, it was a challenge at that time in Amsterdam because there's a limited number of community services out there to be able to meet every patient's need. But as we continue to grow and we look at these trends, it will continue to improve and we'll be able to have more services for patients. So this here is some more data that was collected off the Unite Us platform. And this was over the past 90 days, showing January 7th, 2021. So this was after our redesign. And it was quite interesting. The age category kind of remained the same, but we noticed an increase in our 55 to 64 years of age population of requiring more needs after this time. And again, primarily more females that were involved. And this here is also from Unite Us platform. This here is the ethnicity and race. So one thing with the platform, you can, compare to your UDS measures. If you collect any UDS measures in your practice, the platform can also help you evaluate that so that you can understand what target population you're targeting for health equity. So some of the community partnerships that I've worked with this care model design, Alliance for Better Health, IPA, that I've been working with them since 2018. A new partnership was MVP Partnership, and they were interested in our telehealth home visit program and the hypertension program. So there was a partnership developed there to focus on some of their patients that were not going to their primary care practice. They had collected their internal data and they're kind of a lost to found patient. So the goal of the telehealth home visit program was to be able to offer the patient a home visit so that we could get them back on board with preventative care. As mentioned, there was a hypertension grant program that was developed as part of this model. And I had also collaborated very, very closely with Schenectady County Public Health. Schenectady County is right now at 8%, which is one of the highest in New York State for maternal, child, and infant death. Rensselaer County is second highest. So the collaboration formed with Schenectady County was to try to help decrease these numbers for maternal child and work together with some of their family services program. And that encompassed another redesign of our maternal child OBGYN sector of the clinic and a whole separate care model design. We worked very closely with Schenectady County with our STD clinics as well. And they were also referring patients for primary care referral for any COVID positive cases. Again, we collaborated with them regarding social determinants of health as well. There has been some discussion with Schenectady County regarding the Unite Us platform. It has been mentioned. So hopefully in the near future, counties will participate and or be able to participate in the Unite Us platform. But the ultimate goal, is to be able to meet the health disparities, use of data mapping to help us to serve the high-risk populations is important in every community. And this particular federal health clinic is hopefully soon going to be getting a mobile health clinic van as well, just based on the community partnerships that have been successfully established with successful outcomes. I thank everyone very much for participating today with the polling questions, and I hope that this is an education delivery that you're able to take some takeaways back for your primary care or health clinics. And please feel free to offer any questions. I will put up my information to contact me. You're welcome to email me or call me, but happy to assist in any challenges or areas that you may feel that you need assistance in. And we do have some time for additional questions if there is any.
Thank you so much, Laurie. This was a great presentation. Nothing in the chat yet, but I encourage our participants to ask anything while we have Laurie here on the line. But I actually have a question. I was wondering if you can talk a little bit about the patient and community response to the home visit program and using the Healthy Together platform.
Yes, that's a very good question. So initially, we were a little hesitant even, you know, we were wondering, okay, how are we going to screen? How are we going to make sure that our staff is kept safe? So when we were designing, we felt that it was important that people go out in twos because there are some bad areas in the neighborhood that we go in. So we went out using a nurse and a nursing assistant. And we do have some male nursing assistants that wanted to participate. So that was very helpful. The community actually, you know, we told the patients that we're going to be dressed in PPE, which at that time was like a full white uniform with even a hood on it. And then of course we had our mask on, and we alerted the patient that they might want to let their neighbors know, just in case, you know, just so that there was no fear in the neighborhood. But we told everybody how we would be dressed before we came. And after a while, I would say after the first week of doing this, we had more patients calling in wanting the service that weren't our patients, because it was just spreading, you know, through the patient to their friends, to family, word of mouth type thing. So we were able to really be successful with the program that way. I think just with patient education, being forthcoming about what we were going to do on the visit, and educating the patient of what to expect.
Great, thank you so much. Again, reminder just to our participants, if there are any other questions, feel free to chat those in now, and we'll wait just a couple minutes, and if we don't see anything come in, we could end the session a bit early.
And while we're waiting, you know, initially when COVID had hit, it was a bit distracting because nobody really knew which direction to head. We didn't know, okay, how are we going to see our patients? You know, those were questions that a lot of the providers were raising. So developing this telehealth home visit program was essential. We have not only seen adults on the program, but we've actually seen children. And right now, MVP is working on an initiative that I've worked on with the state of New York, because once the emergency preparedness was lifted, it kind of limited what we could do with children in the home. We can't give any type of vaccines in the home under the current state. Under the emergency state, yes, like you could do anything under the emergency state, but once that was lifted, that limited us on being able to provide care to children in the home. So currently MVP is working with Department of Health in the quality insurance sector. And we are trying to advocate that children be vaccinated. We know that in the state of New York, vaccination rate right now is very, very low because of COVID. And I'm hoping that we're going to be able to, put a pilot together and be able to do that and show that we can get children vaccinated, and that would be very successful to getting care and meeting patients where they're at. We've identified that, some patients that are single mothers trying to come into a clinic or primary care, they're not always able to get in because of transportation, and they've got a number of children that they're taking care of. So wouldn't it make sense to meet the patient where they're at? If we could go to their home and see their children, get them vaccinated, assess them for social determinants of health. So we're hoping that our ultimate goal is to advocate and have a pilot program in that direction.
Thank you, Laurie. That sounds like an amazing idea that the community would definitely benefit from. With that being said, we do not have any other questions in the chat, so we can go ahead and close out the session. We want to thank Laurie for taking the time to present on this program initiative, and we hope that you can all join us at 2 p.m. for our next presentation, Partnership Through a Pandemic, Supporting Veterans and Care Partners Through Alzheimer's Disease. Thank you, everyone, and have a great rest of your day.
Thank you.